So I think we go for the last lecture, and there was a last minute dropout. So I think, Mehmet, one of the tasks of a moderator is also to replace a speaker. So I'm giving my lecture to replace Dr. Lafuente on cervical arthroplasty. Okay. So as you know already, I'm from Portugal. I have no disclosures relevant for this presentation, and you know, I think there is a cost noise, which is not certainly a patient-related factor when we discuss about fusion or arthroplasty. Unfortunately, in my country, I have no bias because the implant cost and the surgeon reimbursement for cervical arthroplasty is roughly the same for fusion. So I'm not biased. I can use whatever implant. I think it's more suitable for the patient. And the topic of our meeting today is cervical degenerative disc disease. And you look here that there is significant motion at subaxial spine where DDD is more prevalent. And if you choose to do fusion, you originate motion loss and stiffness. And as you see here in this biomechanics study, arthroplasty shows similar features to an intact segment. And this is what you get when you do arthroplasty with 10 years outcomes, long-term preservation, the range of motion, despite the occurrence of 42% of HO in this patient. This is a study that we've done with my PhD student, Philippe Pagaimo, and we show that after 1 year, using this kind of prosthesis, mobile core prosthesis, the center of rotation normalized in this position 1 year after surgery. And this is very important. This is critical for outcome, as a change in center of rotation will negatively affect segmental and global range of motion. What happens to adjacent levels? Significant hypermobility, especially in superior disc levels when you do ACDF. Looking here at long-term results, 10 years, hypermobility did not occur in adjacent segments. Also, you increase the intradiscal pressure. It's not only hypermobility, it's also increasing intradiscal pressure of adjacent segments. And the combination of two will speed up adjacent segment disease. And if you look at multi-level fusion and aging, with aging, you normally increase your cervical SVA, and this will increase enormously the adjacent disc load. The pressure in the discs will be increasing with the changes in SVA. And if you do multi-level, this just amplifies the increase in stiffness and the increase in range of motion of adjacent levels. So you agree with me that this rigid construct is very different from this situation where you can preserve motion. And bending forward is the most effective. There is 40% reduction with multi-level anterior cervical fusion. And this is the range of motion you need for daily situations like tying shoes, backing up a car, washing hair. And this is what you lose when you do on sagittal plane, on coronal plane, or horizontal plane, and when you do multi-level. So I think multi-level fusion has a negative impact on cervical spine global functional status, and that these are poorly tolerated when you assess quality of life in patients, especially young patients with higher life expectancy. They are not all happy as this lady here. And multi-level fusion comes also with pseudoarthrosis, and here are listed the rates of pseudoarthrosis. The more levels you do, the more pseudoarthrosis you have, and need for reoperation, it's almost 1/4 of patients. Adjacent segment conditions as well. This is one of patients that operated in 2014, ACDF, and developed adjacent segment disease. He had a completely disc collapse in C5, C6, C7, and I was able to reformat and inserted these approaches on the adjacent levels, and look how nice the alignment and the mobility over the years with 68 months of follow-up. Second surgeries at the adjacent level the incidence is follow-up dependent. As you see here, the more you follow up the patients, the more you see difference between reoperation for arthroplasty and ACDF. Another study with another device showing significant difference adjacent level surgery. What about the cost utility? Real world data from large national insurance database published by Radcliffe. Cervical arthroplasty was 12% cheaper, and this is due to less incidence of reoperation. You have also superior clinical outcomes comparing fusion with ACDF. As shown in this paper, with 5 years follow-up, cervical arthroplasty is highly cost-effective compared with full-level ACDF in long-term follow-up analysis, more than 5 years. So arthroplasty, higher overall hospital costs, but less reoperation, less complication rates, increased return to work. So it's quite effective surgery over the lifetime of a patient, assuming a procedure, 20 years prosthesis survival. Cervical arthroplasty is probably the most scrutinized implant in spine surgery. Many high quality data studies with different devices, long-term outcomes showed that there were not inferior results with arthroplasty, and the more levels you do, the better results you have. And I'm convinced that none of these studies that I showed before were done with third generation devices where you have 6 degrees of freedom, and you probably will have better results with the compressible disc prosthesis that will allow a more physiological location of the center of rotation and offloads also the facet and adjacent discs. So better quality and range of motion, less hypermobility, less adjacent disease and reoperation. In order to validate arthroplasty, we need to understand what's the impact on sagittal alignment. As you've shown before, anterior cervical spine surgery, relief of pain, preservation of improvement of neurological function, and this is related with the quality of decompression, but it's also important to restore sagittal alignment. And probably the most important is horizontal gaze. All other concepts can be somewhat arbitrary, and I show you here significant variation of normative values for lordosis, for SVA, for T1 slope. Of course, it's important to correct such imbalance because kyphosis and increased SVA leads to neck pain and myelopathy progression, facet joint and adjacent degeneration. We look at one of our earliest patients, 35 patients. These were the levels operated and a good increase in index level lordosis and global lordosis. And increasing global lordosis derived essentially from increase in index level lordosis. This has been shown in this meta-analysis, which shows also that a low pre-op T1 slope is helpful in restoring sagittal alignment in kyphotic patients. So this will be the ideal patients for you to start to use arthroplasty to correct sagittal balance. It's also a positive impact on the sagittal alignment of the adjacent levels, as shown on this meta-analysis, either in cranial or caudal levels. So what about index level kyphosis? We've shown that there might be a benefit on sagittal balance overall, but why kyphosis at index level is still a contraindication for arthroplasty. And this relies on the work of Keane, showing that only 13% of pre-op kyphotic index level became lordotic, whereas 1/3 of the patients that were pre-op kyphotic became lordotic. So it seems that arthroplasty is more efficient in correcting lower lordosis than the index level lordosis. We did a study with 23 patients, 25 kyphotic levels, all kyphotic levels. These were the levels operating, and there was a significant increase in all patients. All patients that were kyphotic became lordotic, in contrast with the study of Keane with a different device. Increase in C2, C7 angle, not significant though. Reduction on the CVA, not significant. And pre-op T1 tilt have no influence on the reversal of kyphosis. Just to show you the case, there was kyphosis, no loss of disc height. Patient had a similar cervical disc X-ray 1 year before the operation, and look minus 13.2 kyphotic level. It was obviously a flexible kyphosis, but not fully reducible. As you see in extension, there is still some degree of kyphosis. And with arthroplasty, a nice lordotic increase at C5-6 to 5.3 plus 5.3. So a remarkable 18.5 increase in lordosis. So gain in range of motion along with better sagittal alignment. With, as you see, we applied the StatView software with a nice reproduction of the quality of motion. So reconstruction of segment lordosis at index kyphotic levels is possible while preserving quality and range of motion. Sometimes the device cannot do all, as you see here, and you have to apply some sort of osteotomy to reformat C5 vertebra and the disc space and a lordotic configuration, and have a very nice, from day one post-op, lordotic alignment that were possible to maintain over the 36 months post-op. So we published this in Mehmet's book, Correction Techniques in Spinal Deformity. Reducible segmental kyphosis, at least in my hands, is not a contraindication for cervical arthroplasty. What about multi-level disease? The more levels you do, as shown here, the better the gap over ACDF, the better results you have. In our study with 5 years period, consecutive patients, single surgeon, single device, we had 21 at 2 level, 11 patients at 3 and 4 levels. You see quite young mean age of patients, an interesting follow-up. And these were the 5, 6, and 6, 7 more prevalent operated levels. And in striking contrast with complete loss of mobility in 3 and 4 level fusion surgery, we had very good range of motion and good alignment, global and index level. And no difference if you perform and if you split the analysis between 2 level and 3 and 4 level. This is kind of patients that I see more and more in my office. Certainly fusion is an option, but it will be very hard for the patient. So we found arthroplasty a very good solution for those patients. And some patients also nowadays come with these collapsed discs, like this kind of patient with a myeloradicalopathy, recompressive level, minimal facet joint because they are still young, but the discs are collapsed. Almost a straight spine here. We do the discectomy and then we do this leverage maneuver to see if there is residual motion, and then we insert the arthroplasty instead of fusion. And look how nicely we reconstruct the height of the disc from 2.6 to 6.6 and all the other levels and this was good sagittal alignment over 48 months with very good range of motion. So a lot of these multi-level myelopathic patients, young patients, I think arthroplasty is a window of opportunity to treat earlier patients with mild, moderate forms of myelopathy with good clinical results. And this is 48 months asymptomatic. Decompression was not compromised. Another patient, same kind of results, and look at the significant increase in the disc height. We identified 28 patients. We have more than this now, but this was a study that we did. 48 years old patients, 39 levels. Look, the mean increase in disc height, a good positive angulation, and good range of motion. So I think in patients with preserved facet joints, arthroplasty is doable in collapsed disc height. And more collapsed discs showed higher increase in disc height and also showed a tendency to higher range of motion. Of course, there are contraindications, significant facet joint degeneration, modic changes, osteophyte, diffuse OPLL, etc. So in multi-level disc disease, each individual level should be considered for arthroplasty. You need to be carefully scrutinized to identify all these contraindications. It's important patient selection and respect those contraindications. Poor candidates for arthroplasty are prone to more complications. And finally, very briefly, and this is for me the most compelling argument for arthroplasty, especially in young patients, are the compensatory mechanisms, biokinematics. While you're aging, you tend to increase your cervical SVA. And what happens when you increase your SVA? There is a hyperextension at C0, C1, and a compensatory flexion at C2 to C7. If you do a fusion in patients like this, young patients, you abolish these compensatory mechanisms that are very useful for the patient. So we did a 4-level arthroplasty in this patient for level disc disease, and look at 2 years follow-up. You see increase in SVA, increase in low doses, C0, C2, a decrease in low doses. Might not be in good direction, but that's what is expected in this patient. Also, this patient with idiopathic hyperostosis, that we did remodeling, we did arthroplasty, and with 7 years follow-up, index level range of motion preservation with very nice alignments. This protein is still mobile, and there was variations over the years at the angles 5, 6, and 6, 7 to adapt to global alignment. If you do a fusion, this is impossible. Just another case very quickly. And range of motion preservation coupled with positive sagittal balance that changed over the year. You can read some of our talks on these expanded indications for arthroplasty in the Mehmet's and Guti book on cervical spondylomyopathy, also published on the North American Neurosurgery Clinics, an article about expanded indications for cervical total disc replacement. So as a conclusion, I think arthroplasty mitigates many of the negative biomechanical effects of ACDF. At long term, shows superior clinical outcomes, less reoperation, higher cost utility. If you do multi-level, these results are amplified to compare single levels. It can promote positive sagittal balance alignment, and there's the capacity to reverse global and segmental kyphosis. In my hands, at least, it's a reliable technique for unconventional cases like the dish case I show you, the collapse degenerate discs. And as I pointed out, it's a window of opportunity to treat younger patients as compensatory mechanisms are preserved contrary to fusion surgery. Thank you.
Yeah, very nice talk. Oscar, you have two questions written on the chat.
Right.
One is about the heterotopic ossification rate.
Right. I mean, it's very, very well in the literature, the ossification rate. The paper I show is about half of the patients. It depends on a lot of factors. I think the most important factor for heterotopic ossification is the end plate coverage by the prosthesis. The more you obtain a good end plate coverage, the less ossification you have. Also bone wax, the anterior edge of the vertebral body. Always remove the OPLL, the OLL, the posterior ligament, the PLL, because it's a scaffold for ossification. Generous irrigation. Don't use devices with keels, and by doing that, you probably be able to reduce this figure of 50%. On that paper of multi-levels, we showed around 20% of heterotopic ossification. On the other hand, also very nice paper showing that despite some degree of heterotopic ossification, prostheses are still mobile.
As I know, the incidence is about 20%.
Yes.
The other question is that how do you make a decision for the size of the prosthesis?
Yeah, but it's not really different from ACDF. Most of the time, we use 6 millimeters. Some devices have also the choice of 5 millimeters, which in people from China or Korea, probably this is most adaptable device. But the choice of the size is not very different from an ACDF. It's important not to rely too much on indirect decompression as you obtain with ACDF, because if you preserve motion, especially lateral bending, if you have not done a proper foraminal decompression, in the limits of lateral bending, you can have nerve root impingement and recurrence of symptoms. So it's important to do a complete decompression, and certainly not use big implants, because there will be facet joint distraction and pain and the chance of some subsidence.
Oscar, can we tell that This is not a substitution of anterior or posterior foraminectomy. This is a substitution of ACDF.
Correct.
Yeah.
Correct.
And,
You know,
and
I
how do
think
you?
the previous speakers highlighted very well this difference. I think anterior posterior foraminotomy is a well designed option for more lateral pathology, compressive pathology. Of course, if you have more central pathology, ACDF or arthroplasty would be the choice.
How do you comment that two-level arthroplasty is more beneficial for the patient than one level? How do you comment this?
Yes. You know, if you look at my personal experience, Mehmet, since the beginning, I was very biased. I think when you do one level ACDF, patients don't lose much mobility. Okay. The problem comes with multi-level. So I'm very biased, and I did a lot of multi-level cases instead of single-level arthroplasty. And that's when you can see the difference, because if you look at surrogate endpoints for outcome like motion preservation, quality of motion, and also the satisfaction index of the patient, certainly the more levels you do, the better results you have, because patients have to keep their motion. They are not so stiff.
I have a question. Do you sometimes do hybrid anterior arthroplasty and ACDF or not?
Of course, of course. You know, when you have multi-level disc disease, you have different levels or different stages of disc degeneration. And of course, for more degenerated discs, slip discs, a fusion would be a good option. So you can do hybrid constructs and save the most mobile discs or for arthroplasty. And, you know, so certainly you have to choose between spondylotic changes of the disc. Also, some of the disc levels are less mobile, spontaneously less mobile, so it's not worth to insert a disc prosthesis. So it's a combination of these two factors. But hybrid constructs are certainly very, very interesting and very good.
Thank you.
Yeah, I think some participants may have get a confusion because there are multiple choices, surgical options for a simple disc herniation. And I will say similar things to what Cumhur has said. But actually, my current concept is that currently I do very few ACDF, and I prefer anterior or posterior microforaminectomies, mostly minimally invasive ways. And ACDF can be just restricted to kyphotic and unstable cases. But arthroplasty can also replace this. I don't know the real indications of the arthroplasty, and I'm not sure if its benefits are really very superior to ACDF. But recently, I do very little ACDF, mostly do anterior posterior foraminectomies.
Yeah, Mehmet, but if you, I think the topography of the compression is very important. If you have more centrally located herniation or osteophyte, whatever, I think it's very hard to do it from anterior foraminotomy or posterior foraminotomy. So, of course, if you have compression at the foramen level, this is certainly a very good option. And as I told you, I'm doing more and more full endoscopic posterior foraminotomies. I think it's a very elegant procedure. Patients are very happy. It's almost on a day surgery base. But for central discs, herniation or osteophytes, I think there is still a role for anterior approaches, anterior discectomy and fusion or arthroplasty.
Maybe our other speakers may comment on the conclusions of this meeting. Cumhur will want to say something, I think.
Yeah, but medial lesion does not cause radiculopathy. So I think indications for anterior discectomy for radiculopathy is very rare. It should be a large disc herniation, central disc herniation with kyphotic. Yes, ACDF is an option, but patient just experience radiculopathy. So it could be treated with foraminotomy, whether anterior or posterior.
I believe that posterior foraminotomy is a much safer option, especially for beginners. As Professor Kim showed us, the V point is really the landmark. Once you identify the V point, you can expose very nicely the nerve root. Of course, it depends on the level of the cervical spine you are, because the projection of the disc in terms of the posterior elements can change. So depending on the level you are, you have to do a little bit more laminotomy, inferior or superior laminotomy to be able to expose the disc area. But certainly it's a very elegant technique, and patients are really satisfied. And you hardly need to do more than 50% removal of the facet zone. It's very hard to see a case where all the foramen is compressed.
Yeah, nice. As far as we are concerned, actually, we do more anterior cervical approach. As far as the foraminotomy is concerned, that we use for soft disc, for lateral soft disc. And those results are extremely good. And I also prefer to do in patients where they have a very short neck, particularly at C6, C7, and C5, C6. His neck is very short. And you find technical, expects technical difficulty in exposure in the anterior approach, then I always prefer to go posteriorly. The point which Dr. Kim showed, using the bone scalpel to remove the osteophyte is fantastic, because we use that in 1 or 2 cases, but that is good that if the nerve root is easily retractable. If the nerve root is too much stretched, I think probably then we may have to think about a little bit worried about it. Now, if we don't have the bone scalpel, then the problem, the smallest little bit is 2.6 mm little bits may be sufficient. So, as we all know that we had problems as far as procuring the cervical arthroplasty, because cervical disc is very costly in India, and we don't have a big system of support from the insurance companies. And that's the only reason Indian doctors are not doing very much of arthroplasty. There was a time about 15 years ago, there was a spurt of a large number of disc replacements, particularly about some of the companies, like brand disc, they were used in a large numbers, and there were also indigenous Indian market also produced, the mobile disc, cervical disc arthroplasty implants. But finally, what happened was that we had problems in the cost effectiveness, number one, and there was no approval from the insurance companies. So I saw in the chat, I saw somebody has asked the same question, how to convince in their country, how to convince the insurance companies to say, go ahead with the arthroplasty. But I personally feel that arthroplasty is very good in soft disc, young man, young people with good, movements, and it's not much of restriction. They don't have a big osteophytes or rigid disc space. And they are very good for arthroplasty. we did a little bit, a minimum number of cases, but not large number of cases. As far as the anterior, the ZOS technique, and very less neurosurgeons do, but some do with ZO technique for the oblique corpectomy. And the technique which was shown was extremely good. So once we know that the vertebral artery and the position of the vertebral artery, because sometimes the vertebral artery is very rudimentary, very small in one area. That's the best case to start with for any surgeon. That's my personal advice. We always used to do the 3D reconstruction with the angiogram, and you find if the vertebral artery is very small and you are happened that the side of the osteophyte is on that side, and that is the best case to do this ZOS technique. That's my feeling. Thank you.
There is one question for Insan Kim. The question is that,
Dr. Jalili.
do you have any opinion regarding UBE posterior decompression? Unilateral approach by bilateral endoscopy.
Yeah, that's excellent question for Korean neurosurgeon. And many Korean neurosurgeon and some orthopedics prefer UBE, that is unilateral biportal endoscopic decompression. And it is very low learning curve than uniportal endoscope surgery, because with assisted with endoscope, it's just like open microforaminotomy posterior with microscope. And so the biportal, unilateral biportal endoscope is promising because the learning curve is not steep. So I would like to come with my friend to the Izmir, Turkey, and Spine Masters in October. Thank you.
Thank you. I have a very technical question for Killinger. When you do your anterior foraminotomy, what is the natural corridor for the soft tissue that you use? How do you?
What is the corridor?
Yeah, the natural corridor.
Length?
But do you? No. I mean, do you do the same for an anterior classical approach?
Yes, same. But you don't need to. You don't need to see the other side of the spine. Just midline is okay to get oriented.
Okay, because the cases that I have done, I bounce medially everything. The internal jugular vein, the carotid artery, of course, esophagus and trachea, everything goes medially. And I go along the SC muscle. And I land in the longus colli muscle immediately.
For the anterior foraminotomy or oblique corpectomy?
For the anterior foraminotomy, yes. And it's a natural corridor as well. You don't have any vessels, any nerves. You only higher up, you have the accessory nerve, but dealing with subaxial spine, it's not a problem. So it's just a technical note. That's how I do it.
Yes, but I find the medial corridor is much familiar.
Okay.
Yeah. I'm very honestly speaking that if you push the carotids and the veins medially, it's much easier. Actually, to me, sometimes I feel much safer because the esophagus is very far away. Esophagus and trachea is too far away, and you can exactly over the muscle. And so the actual when we started this anterior approach, many times we have gone lateral to the carotids, and we realized that we had to. So, but that is now more familiar for this approach, because even the drilling must be much easier, the angle of the drill. the angle of the drill to the osteophyte must be very quite easier than, I don't know about what Kumham says, but he is comfortable with. I like to ask you one. I mean, one of this question is that you like to prefer to go on the right side osteophyte through the right side, or the left osteophyte to the left side?
Anterior foraminectomy?
Yeah. For example,
Sure,
that
yeah.
if you have one on the left side, would you prefer to go the left side or from the right side?
This is it's a lateral surgery. With oblique corpectomy, you can reach to both sides, but for anterior foraminectomy, you need to choose the ipsilateral side to the lesion.
Yeah, me too. I always change my position according to the side of the lesion. Yeah, Yahya, do you want to say something?
Yes, I write to the Oscar a questions on board, and I want to ask Oscar for multi-level arthroplasty, because sometimes we see subsidence for multi-level arthroplasty, and biomechanics is different in upper level cervical and lower level cervical. In upper level flexion is more than lower level, and sometimes we see subsidence in between C4 and C5 arthroplasty. And what do you think we should choose, hybrid system or different things? In our clinics, we use posterior microforaminectomy and ICDF frequently, and we use very rare arthroplasty for only single level young patients and soft discs, for example. But do you see in your presentation a lot of multi-level arthroplasty?
Right. Yeah, thank you. Good question. You know, I don't think the principles of subsidence in cervical arthroplasty are the same as ACDF. If you got a good end plate coverage, you don't violate the end plates while you're drilling. If you don't have a kyphotic configuration at the end of the operation, I think you can avoid most of subsidence in arthroplasty. Honestly, I don't see a big problem. What seems that can be a problem, and we are doing a study on that, it's starting to show on the literature, is anterior osteolysis with a cervical arthroplasty. That we don't really understand the nature and the timeline of this anterior osteolysis, which means decrease of the disc of the vertebral body height, anterior vertebral body height. I don't see much on my patients, but this is certainly something that we are studying now, calling all the older patients and look at we don't see it with a clinical significance, but it may exist. So we are calling all the patients now to make this study. So this might be a more relevant problem than subsidence. I think if you keep the rules of ACDF and you apply to arthroplasty, you don't have much subsidence as well. So good end plate coverage. Don't avoid kyphotic configuration of the disc at the end of the operation. Careful with drilling, you end up not having much subsidence. And regarding your hybrid technique, I think it's really useful. You know, this was not really the topic of my presentation, but it's certainly something I got because, as I explained, when you have multi-level disc disease, you have different stages of disc degeneration. So some of the discs are more spondylotic, some are less spondylotic. So obviously you apply arthroplasty to less spondylotic and fusion to more spondylotic levels. Or if you have some economical constraints, you can use ACDF in the less mobile levels. And we know that cervical spine doesn't move all along with the same amount of range of motion. So you can play a little bit on that. But certainly it's a very good option and I do it.
Thank you.
Dear Mehmet, should we conclude?
I think yes, we are. You must come to the end. It was very nice overview of. I congratulate all the speakers.
Thank you,
Thank you.
Mehmet, and congratulations
Dr. Zilli.
for organizing this.
Maybe we can get
webinar.
a photo of all
Yes,
if
yes.
you open your videos.
Yes.
Also, the participants, can you please open your videos? Thank you. Thank you. Thank you for coming to this meeting. I thank Oscar for moderation, and I thank all the speakers.
Thank you, Mehmet, for organizing
Hope to
this
see you again.
webinar. And Onur, also nice to see you. Onur, please continue to organize this we
Yeah.
had very profuse discussions and very technical detail. So it was really useful. I learned a lot.
Yeah.
Thank you. Here from anterior foramen. Here from anterior foramen.